Today on Accidental Experts with Bryce Hamilton.
Welcome to the Accidental Experts podcast. I'm your host, Bryce Hamilton. I'm a licensed clinical social worker and a child and family therapist. I have been in practice for over 15 years, and I'm also a mom of 4. So I know the challenges both professionally and personally. I'm so glad that you're here today to grow your parenting toolbox. Please come as you are and be ready to learn. My goal is to make you the accidental expert so that you can raise healthy humans. Hi, everyone. Welcome back. I'm so glad you're with us today. So we are going to be talking about such an important topic. We're going to be talking about what to do if our kids are having suicidal thoughts, if we are just a parent who is wanting to be thoughtful about opening this door to talking to our kids about suicide so that if that happens, and it does happen for a lot of people, that they feel like they have the resources and the support to talk to a grown-up about that. So we have Julie Goldstein Grumet, who is the director of the Educational Development Center, and she is also the vice president of the Zero Suicide Institute. And she is going to talk to us about what to do and what we know about suicide now and how we can protect our kids. With that, let's get to Julie.
Yeah, thank you for having me.
Yes. So this is such an important topic. I mean, I think, we are talking in our society about suicide a lot, where we're getting a lot more time to this word because I think we've been so fearful of the word suicide. We don't want to talk to our kids about it. We don't want to talk to our teens about it. We don't want to ask anybody about suicide because we're so afraid that we might plant an idea in their mind or scare them or hurt them in some way. So I'm so glad you're here.
Actually, I think it's partially that, and mostly because most people would have no idea what to do or say next, and it would be terrifying to ask and have somebody say, actually, yeah, I do think about that. But yeah, I think we've come a long way as well. So
yeah, no, you're so right. I think, yeah, the second part is if you did ask or said something, then what? There's so much that we don't know what to do as parents or employers or friends or siblings, right?
Or even like nobody I know would ever do that, right? Mm-hmm. Like also that idea of, no, that would never happen to me. So.
Yeah. So much stigma or presumption about who is suicidal, who has suicidal thoughts, and what that looks like. So I'm glad you're here today to help us kind of navigate through this. So you work for the Zero Suicide Institute. And can you tell us about your mission?
Yeah, so the Zero Suicide Institute is at the Education Development Center. EDC is a global nonprofit, and we've been working in health and mental health for many, many years. In particular, I oversee all of our suicide prevention efforts, one of which is the Zero Suicide Institute, which we are really tasked with trying to advance the Zero Suicide Framework, which is how we want healthcare systems to use best practices to identify and care for people at risk for suicide. It's really important that we use the evidence that works, that we use them consistently, that we train people to use these best practices, and then we examine the impact. Is it working? And what can we improve? So we want healthcare to be safe for anybody thinking about suicide, whether you walk into primary care, the emergency department, community mental health, even oncology, neurology, OBGYN, that any door is the right door to disclose your thoughts of suicide, but also that the burden is placed on the healthcare system to ask you directly at every visit about your thoughts of suicide and then have a game plan to take care of you and minimize those thoughts.
Yeah, because I think even when you're looking at medical care, and sometimes even within my own profession, right, of therapy, some therapists really don't know what to do with that disclosure, truth be told. But I think especially in medicine, right, when you're looking at physicians, they're busy doing other things too, right? And so sometimes they don't have the right training or the thought to ask. And so that's so important that we're asking people in all settings, because then we're going to catch more people that are in that place to make it safe for them to disclose so that they can get help Because it is a huge burden to hold that in all to yourself.
Well, and the issue is a lot of providers, right? I'm in my 50s, and most of these evidence-based practices were not, they weren't around when I was in grad school for clinical psychology. So much of the research has emerged really in the last 20 years, 15 to 20 years, and it's continuing to emerge. But so you're looking at licensed psychiatrists, psychologists, social workers who, are in their 50s, who finished grad school long before 15, 20 years ago in many cases. So no, they were never trained in these practices. They're not required for licensure. They're not required for continuing education credits. So we're really asking people to know something that, frankly, why would they know? We'd hope they would. We'd hope, just like in fields like, dialysis machines, new dialysis machines exist. You get trained in using that technology. New medicines emerge for cardiac care. You learn about them. You read all the journals. But I think in mental health, suicide prevention is just not something that everybody universally is up to date on. And so part of Zero Suicide, again, is really taking that responsibility on as healthcare leaders, so that the healthcare CEOs, healthcare leadership says, yeah, we don't expect all of our providers to know this, so we're going to make sure that we teach them, train them, and ensure that they have access to the resources to utilize these best practices. It's only fair to them, and it's only fair to our patients.
Yeah, absolutely. Love that idea. And I love that you guys are taking the initiative to make this happen. So that's lovely. Thank you. Okay, so what have you guys learned, or what is the research showing that we know now about people who have suicidal thoughts or suicidal attempts or intention that's different than maybe what we previously understood?
Well, I think one of the things to think about is sort of how you started our conversation, which is, I think, this idea of, can you put the idea in somebody's head? If you ask, will you make them angry? And I think the research has really demonstrated that you're not putting the idea in somebody's head. If you ask directly about thoughts of suicide, people generally want to tell you. People have been very traumatized over the years in many cases by sharing their thoughts of suicide, whether it's been minimized, oh, your life is so great, why would you even think that? Or they've had healthcare providers, as we've already talked a little bit about, who aren't well trained. So they went to healthcare, but they didn't find that their symptoms got any better. So I think what the research has shown is if we ask directly, people's anxiety actually goes down because they feel like, oh, okay, this is a safe place to talk about this, and you do want to know. On the other side, I think that we as providers have to know what to do. And I think the research has shown when we utilize these best practices, standardized screening tools, standardized risk assessment, we use safety plans, we just talk about reducing and removing access to lethal means during the time of acute crisis. We use treatments that work, that directly reduce the thoughts of suicide. We directly target those thoughts and behaviors. And we really do strong care transitions. We don't just say, so Bryce, you really should see somebody, here's a list. But rather we make it that linkage much more supportive. You could go see Julie. I know her. Actually, we could give her a call together right now. Let me tell you a little bit about her. And then I check in with you, a day or two later. Did you call, or have you seen her? How'd it go? Right. We do all those kind of follow-ups. My vet calls me. If I bring my dog in for a visit, my vet calls me to check in on her. So these care transitions are really important. And the research shows these evidence-based interventions work to reduce suicide. So we have to use them, and we have to use them consistently, and we have to use them with fidelity.
So I'm thinking about your program. Is it something that people can refer family members to, or their kids, or is it really for professionals?
Yeah, that's a great question. So Zero Suicide emerged from the last National Strategy for Suicide Prevention, which is really the country's roadmap for how are we going to reduce suicide. So that the last one was released in 2012, and the most recent iteration was released in April of 2024. And that's our roadmap. And Zero Suicide is included within that as one piece of a comprehensive approach to how we can address suicide in this country. zero suicide is a model. In examining what works, we know that it's not one singular intervention that works to reduce suicide. Similarly, we don't want schools to just do an assembly once a year about don't tell somebody if you're thinking about suicide and then think, okay, we're done. We don't want healthcare. Ask once a year and think you're done. We know that you have to really use a comprehensive approach to reduce suicide. Zero suicide emerged through looking at what does work in healthcare. And so different models and different healthcare systems over the years, particularly the United States Air Force in the 1990s, had used a comprehensive approach. And that was a really strong indication that when you utilize all of these evidence-based practices together simultaneously as a clinical care pathway, consistently, you train people, you measure, are you actually doing what you think you're doing, that you can reduce suicide. So that's really what zero suicide is. It's a framework using 7 elements that we know work. There's a set of clinical elements that I briefly just spoke through, and there's a set of operational elements. How does the system, how does the clinical leadership really think about suicide care? And when you use this infrastructure plus these evidence-based practices, it's been shown to reduce suicide. We don't want parents or individuals necessarily walking up to a healthcare provider saying, okay, are you using zero suicide? But frankly, there'd be nothing wrong with that either. We do want people to be informed that there are best practices that exist. And just like every other kind of medical issue, you should advocate. Tell me your training in suicide care. Tell me how you'll plan to reduce my thoughts of suicide or my child's thoughts of suicide. Tell me about that, right? You get to interview your provider and say, can you make me feel better? Really, zero suicide is how the system adopts these best practices. And so we really do want systems to think about how are they consistently embedding these best practices and then improving so that they're driving their suicide rates down.
That makes sense. So you're the framework to teach all the entities how to implement these best strategies so that schools, places of employment, hospitals, physicians have access to how to support their people.
Yes. And so there's a free toolkit. It is zerosuicide.edc.org. There's a lot of healthcare systems that have looked at that toolkit and say, yes, this just makes great sense. And through really dedicated leadership who are driving their zero suicide initiative, they can use that toolkit to kind of drive their adoption and implementation of zero suicide. So anybody can use the resources on that toolkit. There's a readiness assessment. Some of the elements that I was just speaking of, they can score themselves on a 1 through 5. How well are we actually doing when we talk about each of these pieces of care? How do we really define what we mean when we say screening or care transitions? It's really important to use people and involve people with lived experience right from the get-go when you're designing your processes and policies. So again, really thinking at the outset, how well are we doing that? So there's a needs assessment, this readiness assessment, and there's also a workforce survey, which healthcare systems can distribute to their teams to have people anonymously say, I feel like I have the training, the comfort, the competence, the skill to deliver on these interventions. And that's a great snapshot for healthcare leaders, hopefully, to look at and say, we thought maybe our providers actually knew more than they do, but it's our responsibility to respond to the results of this survey and ensure that they have that training and comfort. Right? Yeah. You want people to feel that they have the competence and the skill to work with people and reduce their risk. What we found through that survey is, generally speaking, it's a 1 through 5, with 5 being strongly agree. Our survey has found that on average, providers have about kind of 30 to 40% say, I strongly agree that I have the comfort and the competence and the skill to deliver on these interventions. And generally another 30 to 40% have agreed that they have this comfort and skill. So overall, that the good news is, 80 to 90% are saying agree, strongly agree. I do this work well. But we really want everybody in strongly agree. We really feel like I often use the example. I have a child with a congenital heart defect, And I often use the example when she was an infant and having heart surgery, had the cardiac surgeon, who sat us down to talk through what he would be doing, said, I haven't done a lot of this. I mean, I have a lot of training in heart surgery, but I haven't really done this before. And I don't know like a ton about it, but I'm going to do my best. And, I hope it goes okay. That is not, as a parent, what you want to hear. You want to hear, like, this is my bread and butter. I've got it. I can do this all day. I totally have the training. I am comfortable in there, and I'm going to do my best, recognizing that, yes, adverse events happen, even in heart surgery, and adverse events happen in suicide as well. We can't necessarily prevent absolutely every suicide, and as clinicians, we have to go into it knowing that, but we absolutely can reduce people's thoughts of suicide, and most often we can prevent suicide if we use the evidence that works, provide hope consistently, and partner with our patients.
Yeah, that's great. So what do you think parents need to know when we're talking about suicide and what we've learned about suicide over the years? What do parents need to know about having either a kid or a teen who is having suicidal thoughts, or maybe they don't know, or their kid reports that they're not, but like, what do parents need to have on their mind?
Yeah, I think parents need to get comfortable asking their kid and checking in with their kid. How's it going? How are you doing? But also really asking very directly, not assuming that a child will necessarily come to you and say, I'm really struggling with thoughts of suicide. I think many parents are afraid to ask that. They feel like, I don't know what I would say, or there is no way my child would ever have thoughts of suicide, or they would absolutely tell me because we're close. And I'm a parent of 3 kids. It's such an understandable way to think. And yet, kids protect us, and they don't want to scare us, and they don't want to make us angry, and they don't want to concern us or burden us. And so oftentimes kids don't tell their parents. They'll tell their friends, and their friends then think this is a secret, and I don't want them to be mad at me, so I don't want to tell. But as parents, I think when we're feeling like something is just a little off, or our child is going through something really significant, or something traumatic happened, or something they're talking about something that happened with a friend, we need to really say, sometimes these things can be really, really overwhelming, and sometimes so much so that people even begin to think maybe they don't want to be here anymore. Do you ever feel like that? Do you ever have thoughts of suicide? Please tell me. Help you. I love you. Let's work through this together. But I think parents have to ask very directly. And it's a very scary question to ask. I know that personally. But we have to ask, and then we have to be prepared to, as a parent, we can talk to our pediatrician. There's a nation's crisis line, which is 988. It's 24/7. You can call from anywhere, anytime, and somebody will answer. You can call today, even if you don't have somebody who's at risk for suicide, just because you want to find out what will happen if I call. But you can call immediately. Additionally, if you do take your child to the emergency department, or your child's in community mental health treatment, if your child is thinking about suicide or has mentioned having thoughts of suicide, it's very important that you absolutely remove all access to lethal means. A gun in the home is incredibly risky when somebody is thinking about suicide. You have to lock it up and ideally get it out of the house. Kids are very savvy. Even if it's locked up, they often know where the keys are. You think, well, I've kept it separate, or they don't know the code, or they would never do that. And unfortunately, that's not always true. So during a time of acute crisis, you have to get lethal means out of the house, particularly guns. Get them out. Talk to the police. Talk to somebody else in your community who could hold on to it. Talk to a gun shop. See if they'll hold on to it. There's different rules in different states, but it's very important. And if your child is thinking about suicide and it's not through a gun, then figuring out what is their means of choice. Would it be pills? Would it be knives? What other things might they utilize? Lock them up, remove their access during this time. Just like if you're out for a night and a friend has drank too much and you say, you know what, you can't drive home tonight, I got you, or you take their car keys away. It's the same thing. During a time when somebody's in acute risk, you have to remove access to the means by which they could kill themselves. So those are some, and the other piece is having a safety plan. As a parent, there are There are things we call safety plans. It's quite literally, what are you going to do? What are the things that kind of cause, how do you know you're in distress? And what are you going to do to reduce that distress? And that is not always, I'll call 988 or I'll take you to the hospital, because over time, you want your child or anybody in your life to learn the skills to manage that distress on their own. So a safety plan is a prioritized list of coping skills. What are my signals that I'm in distress, and what can I do? Some of which might be sort of very individual, things that are very unique, though, to you. Maybe reading a book, taking your dog for a walk, watching, Lifetime movies, whatever it is. Some of it may be calling friends, not calling therapists, but calling friends, not to talk necessarily about your suicidality, but just to say, when you get that call, I just need somebody to be around me. I need you to play cards or distract me, talk with me about other things, go for a walk, watch a dumb movie with me, and preparing those people. Maybe it's your aunt who lives around the corner, but preparing those people for what you want them to do when they get that call. Mm-hmm. So a parent should ensure that their child has a safety plan, that they know how to use it, that they've talked about it, and then just check in with their kid. Are you using it? How's it going? How can I support you? How will I know when you need more support? For some parents and some kids can't just say, hey, Mom, I'm kind of having those thoughts again. They may even want to rate it on like a red, yellow, green kind of day. Mm-hmm. Yeah, today's just a red day. And that's an alert to a parent to be like, okay, you know what? I'll work from home today. I'll stay close. Or it's a number system, but finding that language to make it a little bit less scary, to bring it into the house, to make it clear that you're partnering with your child.
Mm-hmm. Yeah, it's way easier to say I'm having a red day than I'm having suicidal thoughts or I want to hurt myself. And some kids do say those things, and some teens do, and adults. But I think making it approachable is key to that part, and knowing that you're partnering for sure. So let's say a parent who's listening to this, they have a kid, they ask them, have you ever had thoughts of hurting yourself or not wanting to wake up, but you want to kill yourself or you're suicidal? They get the answer, yes, I have had those thoughts. What is I know getting the lethal means away, but what do you find is like the first thing that parents should do? Because I think in that moment, if you're not prepared, it would be quite shocking. So how do you find it's best that parents respond in those moments?
Yeah, I think certainly saying, okay, we can work through this together, and thank you for telling me. Mm-hmm. I want you to always be honest with me, not freaking out, because mm-hmm. then you want them to tell you the next time. And then part of it is really figuring out, there is really a difference between kind of how bad are those thoughts on a scale of 1 to 10. Like, do you have a plan? Do you have something that you're actually right now thinking about doing so that you understand, I know where Daddy keeps his gun? Or is it, no, I just so tired. I just can't take it, right? To try to give you an indication of the severity. And we're not asking parents to be mini therapists or mini psychiatrists, but certainly that what is the level of risk in this moment? It's kind of a key question if you're asking about, is it so bad that you want to be dead? Or is it so bad you just don't want to feel this way right now? It's exhausting, because those are two very different pathways. One, it's so bad I want to be dead and I think about it all the time. Yeah, you really should take your child to the emergency department, especially if this is the first time they've said that and you don't have a safety plan and you don't have a therapist, and so you don't already have sort of a well-worn groove for, okay, this is what we'll do. Yes, I would take your child to the emergency department. If it's the first time and they're saying these things and it's more of, I don't have a plan, I'm just so sad all the time, or I'm just so frustrated all the time, or I just feel like I can't take it. I hate feeling like this. I would make an appointment to see their pediatrician so that there's more of a more in-depth screening and assessment and determination. Not every child has to go to the hospital. And a lot of kids won't be admitted, right? The statistics are about only 8% of kids who go to the hospital with thoughts of suicide are admitted, and that's because of sort of these things that I'm saying, where not everybody is at imminent risk and needs then and to be hospitalized. And hospitals absolutely play a role in our continuum of care for this, but I also don't want parents to find themselves surprised that they take their child to the emergency room and think, okay, that's great. They'll stay here for a week or two and they'll get better. And sometimes that happens, but more often than not, you're going to be sent home and you're going to have to find care in your community. And if care is delayed, because it really is hard to find a good provider and appointments can be really hard to get, if care is delayed, then look up safety plan. It's suicide safety, suicidesafetyplan.org. Just call it a suicide safety plan. Look it up. You can download, there are apps for it. You can download it. You can walk through creating a safety plan with your child. So those that prioritize coping list I was just describing a moment ago, you can do that with your child, and you should understand it. If you do take your child to the emergency room, know that, as I already said, oftentimes they won't be admitted, and you have a plan to find a community provider. If they are admitted to the hospital, generally their stays are 3, 5, kind of 7 days at the most. They're often not getting treatment to directly reduce their thoughts of suicide. Treatment takes a long time. And so they'll get some treatment, they'll often put on medication, but they're not necessarily coming out of the hospital as though they had surgery, where you fix the appendicitis and now they're home and they're done. Mental health and thoughts of suicide is just not the same thing as surgery and appendicitis. They will have to continue in outpatient care. So be prepared for that. It's the beginning of their journey. It's not the end and the fix.
Yeah, I think that's important to know, because a lot of times we view the hospital as that, but it's just crisis care. It's to get them stable enough that we can work at what's going on for them in the community, really, is where, for me, I think about it as a clinician as like it's a holding place for them to get to a place where they can stabilize enough to be in the community. And so I think that's hard for parents, because they really want their kids to be back to what they viewed them as their normal self before this incident happened, or whatever is going on. And that's not what happens, but it can, right? Like we can get to a place where we're stable and feeling healthy and happy and finding joy, and working through whatever things happen to lead them to that place. But it does take work, and it involves, with kids, like oftentimes the schools are involved in this, right? Creating a supportive environment, and also at home, making sure that we're supporting our kids, and also including their doctors, because medication can be a helpful tool in supporting people who are at this place of having suicidal thoughts. And I was going to say, I have this cool thermometer that somebody made that I got off of LinkedIn that I love, that I use in my practice. And so I'll include that in our show notes, but it talks about the different names for like, what is suicidal intent, right? Versus suicidal thoughts. And it kind of breaks it down to talk about, do they have a method? Do they have a plan? Do they have intent? And I think those are important parts. And so I use that in my practice now to help kids and adults to describe where they're at on that. And I think that's really helpful, because then we kind of know where they're at. It's not that you can't take your kid to the hospital at any time, but that's not always the thing that they need. But if your gut is telling you that's what they need, please follow your gut feeling and allow the medical professionals and therapists that are employed there to determine where they're at. But I think a lot of times when we talk to them, we might find that there's no real plan or no real intent sometimes, right? They just feel like they don't want to do this anymore. They're tired. I just don't want to live. But they don't really have the intention behind that. But we have to get that from our kids or our teens or whomever we're speaking to. They need to put that into words. And something I also talk to kids about is like, do you think that you need to go to the hospital? So like I might have looked at, we might have looked at the thermometer and I'm like, okay, like this, as a therapist, it doesn't feel like they need to go, but I will always ask, do you think that you need to go? And sometimes I am surprised that sometimes they will say yes, even though, my clinical judgment was going to say like, we're kind of in a place where we can use a safety plan and these other methodologies, see them more frequently, whatever that is. see their pediatrician, but they say yes, then I say you take them for sure, right? Because sometimes they're scaring themselves, right, with these thoughts,
Yeah.
and so sometimes that helps them to feel better when somebody else says, here. You like, we can't go home, or we do need to be hospitalized, whatever it is. Or sometimes they might be holding something back, right, to not share. And if they think they need to go, I definitely think that is a reasonable next step.
And I think, everything you said, I totally agree with. I think one piece of that is that we have to take kids seriously.
Mm-hmm.
And again, I've seen so many times where parents or school teachers or others kind of say things like, oh, you have so much to live for still. Why would you ever do something stupid like kill yourself? Or even in our asking, we ask it in ways like, well, you're not thinking about doing something crazy, are you? And that is not the same as asking directly about, are you having thoughts like you wish you were dead, or are you thinking about killing yourself, right? One kind of suggests, A, I don't really know what I'll do with that answer, or B, I think suicide to me is so crazy that, I can't even fathom it. And so that really shuts down a conversation very quickly. We have to take it seriously I think when you're 15 and your friends aren't speaking to you, and a boy maybe, just ended a relationship with you, you don't have a lot of life experience to realize, you know what, this is kind of the roller coaster of life, and there'll be another up, and I'll get through this. You have very limited experience. And so, sure, as an adult, as a 50-year-old woman, I can say, yeah, that's like, don't kill yourself over that. It's that girl who was mean. That's so dumb. You have so much. You're so wonderful. You're so beautiful. You're so everything. But to, that child, she's thinking, I literally don't have anybody to eat lunch with. Nobody wants to be my partner in school. I am miserable walking in the halls every day, and I can't imagine doing that anymore. And we need to hear that and understand that for that child, how real that is. It doesn't mean that child will go on to kill themselves, but we do need to validate like that. Yeah, I do hear it is really bad for you. Tell me how bad it is for you. Help me to understand it. Is it so bad that you actually think you would kill yourself? Do you have a plan? Tell me more about that. Right? As parents or as school teachers or as others, we need to not shut that conversation down out of fear or out of judgment, because kids pick up on that in a heartbeat and they'll shut down.
Yeah, absolutely. Well, because like you said earlier, they don't want to scare us. They don't want to burden us. And yet, as a parent, like, the thing I want my kids to do is I want to share it with them, whatever it is that they're going through, whether it's good times or hard times or in the middle. It doesn't mean that I have all the answers, but I want to do it with them. So it's okay as a parent to not have all the answers, because as a child therapist, I don't have all the answers. There are times where I tell my kids, like, we're going to figure this out, right? Like, we're going to figure this out together. And I think that's the important part, is not to be like, I'm so scared. And I know sometimes parents have tears because they're like, it's hard information, but as much as you can think like, I'm so proud of my kid for telling me, this means we can do something about this, right? Like, we can actively get help, going to the emergency room, contacting your pediatrician. If they have a therapist, reaching out to that person to get support. I think all of those things are really important. So what can we do as a community? I'm sorry, were you going to say something?
Yes, I realized we made a video, and I absolutely want to make sure parents know it's available, because so many of the things we're talking about right now, we interviewed parents and we interviewed experts, and we put it together in this hour-long video. It is available on the Zero Suicide website, so zerosuicide.edc.org /resources-parents. So it's in the parent section of the Zero Suicide Toolkit, and I think you'll have some show notes or a place where parents can find this.
Yeah.
If you Google Zero Suicide parent video or suicide attempt video, I think you'll find it as well. The video is designed as though, kind of like the way you and I are talking right now. So like we're sitting at Starbucks or we're sitting and talking, and I'm saying, I don't know what to do. What do I do next? How do I help my kid? It was designed, it's called After Your Child's Suicide Attempt. And it is designed for exactly this moment. Your child has just talked about thoughts of suicide or made a suicide attempt. They may or may not have gone to the emergency department or spent time in a hospital. But now what? Both, I'm carrying a lot of feelings as a parent, everything we just talked about, anxiety, fear, anger, but also hopefully hope. And what do I do? What is the safety plan? How do I find a therapist? Do I let my child go back to school? Do I have to sleep in bed with them every night? Do I let them go out Saturday night with the car to a party? How do I parent given what we've been through and my fears? And so we tried to interview many parents who have been there, who can just validate those feelings and talk about their experience, and then also some experts to say, what should parents do? So we want this video to be widely distributed, and I hope parents will watch it and find it both helpful but also hopeful.
Yeah, that's amazing. I did not know that resource was out there, so I'm so glad that you shared that with us. So what do you think? We talked about what parents can do, and we talked about like healthcare providers, but like as a community at large, what can we do to support people who are having suicidal thoughts or intent, or just like maybe even just raising healthy humans, right? As a community, what do you think we can do?
Yeah, I think what you're really talking about is what we call upstream suicide prevention, right? We've been talking a lot about sort of the point of crisis and acute suicidal thoughts, but really what we want is to lay the groundwork for a healthy community, for people that have the skills to manage distress. Ideally, kids learning things in kindergarten, first grade, sort of that anger management, social emotional learning, social skills, navigating challenging and big emotions, talking about it, reducing trauma, reducing exposure to traumatic events. We want to give kids certainly healthy living, places to live and eat and work and pray where they feel safe and cared for and have caring adults around them and role models and people that they can talk to that reach out to them. We want communities that offer, where their suicide prevention strategy incorporates more than just the suicide prevention and mental health field. You need faith, you need workplace, you need sports, you need coaches, you need all the other sort of social determinants of health, things, housing and food instability. You need all of them at the table together, exposure to substances, and thinking about how can we drive down those many challenges that ultimately can, in the long term, lead to thoughts of suicide, improving access to care, but also kind of upskilling people in just being connected. We know that, not everybody needs to go see a mental health therapist. Yeah. But being connected at your school, in your community, in your house of worship, being connected and just having people to spend time with you that feels positive, that makes you feel good. All of those things are very, very protective in terms of less acute stress later in life. Those are some ways I think that communities can, really come together and think, how are they addressing these? And we often do that in a very siloed way, right? These different entities don't work together, but our challenges that we experience in real life are not so siloed. So pull our resources together, I think we can accomplish a lot more.
Yeah. Well, and I think it's also, I'm thinking about coaches, right? Like if you're a parent who's coaching your kids or a team, like being really encouraging and positive and taking time to like notice every player, like, hey, I thought you did really well at this today. And even though that's maybe not talking about the suicidality that we've been talking about, this is like the preventative, the bubble that we're kind of creating to create a cushion around our kids, not to protect them from everything, but to give them some space, right, to exist and to go through hard things and kind of develop some resilience. Because it's like, hey, Coach Bryce said this, I'm really working hard. I'm a really hard worker. And that might be something that helps me to keep going, just knowing that other people believe in me and that I'm doing a good job. So I think teachers can do that, different places of worship, like just like noticing people. I think sometimes we get so into our own world that we forget that there's other humans just like around us all the time.
Yeah. And I think normalizing these conversations, right? So if a teacher is doing an assignment and there's a character with mental health issues, just really not making it an other, but rather this idea that lots of people in our lives suffer from mental health issues. We may have people in this classroom who see therapists. Your parents may have, and that's okay. What would you, and this idea of really instilling in kids, if your friend talked to you about thoughts of suicide, what would you do? This can be conversations over the dinner table because you watch a movie together or because something pops up in the news. What would you do if Kelly told you she was having thoughts of suicide, right? I think often kids will say, well, I wouldn't tell anybody. I wouldn't want Kelly to hate me. And really, as an adult, saying, actually, the best thing that you could do would be to tell an adult. And if you couldn't tell me, could you tell Aunt Sue? Or could you, tell somebody else, your coach, your teacher, somebody else? Who would you tell? Kind of almost that role play practicing and just normalizing that these are conversations that are going to happen, but that it's not, it doesn't have to be so scary. That just like if she was throwing up in the bathroom with a stomach crisis day after day after day, you probably wouldn't keep that to yourself. You'd probably say, I'm scared for her. I want her to be okay. So we have to say, great, this is the same thing. We just want your friend to get help. We want people to have these conversations in school when they can, as you said, whether it's the sports coach, the faith leader, the Girl Scout troop leader, just so that it becomes very embedded that this is just not any different than, your brain is just another part of your body.
Yeah, absolutely. I love that. Yeah. And I talk to kids about like kid-sized problems and grown-up sized problems, and having a friend who is thinking about hurting themselves or has shared something like this with a kid would be definitely a grown-up sized problem, just meaning that we need grown-up help, and that's totally okay. And kids do worry about the friend not liking them anymore. And what I've talked to my own kids about, or kids in my practice, is like, if they get to they're going to live through that and we'll work through that then. Right. Yeah. And so that is a problem for tomorrow because you're helping them now so that we can get to that. And actually that would be an okay problem, right? Like that they're here so that we can work through that. And I know it feels bad, but we can do this, and I'm here to support you in that. And so I think the conversation ahead of time is so critical. And so I think parents often don't think about talking about this ahead of time when our kids are little and they're actually listening to the words that we're saying, all of them. Right. And so I think elementary school is a good time to bring this up, because as we move into middle school, there are elementary school kids who do think about killing themselves or hurting themselves, or they're having a hard time. And so the more that we provide language, the less they think they're the only person that's ever thought of that, and that they know what to do. It's protective for our kids actually to know what to do in these situations. And then you have some time to also think about how you're going to respond if that comes up.
In my house, so I have 3 teenagers, and, the conversations we've had over the years, we've talked about sort of kind of okay secrets and not okay secrets, right? It's okay to keep secret that, your brother has a crush on somebody. I don't need to know that. That's his business. That's an okay secret. It's okay secret that somebody got an F on a test and doesn't want to tell me. It's not an okay secret if somebody's hurting themselves or somebody's hurting them, or they're doing something that can get them hurt, right? It's not an okay secret to find out that somebody's having thoughts of suicide. It's not an okay secret to find out that somebody touched one of your bodies when you didn't want to be touched, right? Those are not good secrets, and you're not doing them any favors by keeping that a secret. Those are secrets that can hurt them, and really trying to help kids differentiate. Part of it's a little bit of tattling that goes on in my house too. It's trying to help on that side of things too, but trying to differentiate. Like, there are secrets I don't need to know. Enjoy. That's the beauty of being a teenager or a tween. But then there are secrets that are they're not secrets. They're very scary events that can hurt somebody I love, or you love, and those are not okay secrets. Those are things you need to pull an adult in for.
Yeah. Well, and that made me think of the people that I have worked with or heard that have had a suicide attempt. And what I have found is that none of them really want to die. That wasn't actually what they really wanted. It was just that that was the only solution that seemed to make sense at that time. So I think, that's the other part is like they want help. It's just scary. Like they don't know what's going to happen if somebody does that. So I think that's a part to remember too. Okay, so let's talk about. I think I hear this idea of parents or people saying when people do have suicide attempts, like, hey, I never expected this from this person, or to have suicidal thoughts. I didn't see it coming. What do you think parents or adults or teachers need to have on their mind in terms of like what should we be looking for, right? Like, or how do we keep that from being a narrative that parents are saying like I didn't see this coming?
Yeah, I mean, we hope that through all these many things that we've already been talking about today, that parents open up, or people around anybody's life, open up opportunities for these kinds of conversations. Ideally, by having these conversations, finding out earlier that somebody's thinking about suicide will emerge. But also trying to take note of things like, is somebody in my world behaving differently? Are they dropping out of activities that they used to like to do? Is their mood significantly different? Are they coming to school less? Are they not performing as well? Is their appearance different? Are they losing or gaining weight, sleeping more or less? I will say that not all suicide is going to be associated with a mental illness. Mm-hmm. We think that's the case, like, oh, if you're suicidal, therefore you're depressed, and that's not the case. Suicide can be associated with mental illness, like depression or eating disorders, or schizophrenia, or bipolar, or substance misuse. But suicide can also emerge much more impulsively. The thoughts of suicide can come on very quickly. It can come on within a matter of minutes. They can also go away very quickly. So again, not having access to lethal means in your house is a huge protective factor. If you notice any of those indicators I was just saying, things, like change in mood, change in behavior, change in appearance, change in participation in activities, then you want to bring it up. What's going on with you? I noticed that, and can you tell me about that? Or is something going on? Can you tell me why? Tell me more about that. Hopefully, not in a judgy way, not in an accusatory way, but in a genuinely curious, empathic, and look at them while you're asking that question. And parents, often it's easier doing that driving in the car. Some kids don't want to look you in the eye, but asking very directly, and then kind of going through. Sometimes when people do that, they're even thinking about suicide or hurting themselves, or having thoughts that they wish they weren't here anymore. Is that something you're thinking about? All those things that we've already been talking about. Hopefully some of those other pieces, if somebody experiences some type of a event, like it is a breakup, or it is something not doing well in school, or there's a traumatic event at school, somebody else died by suicide, or somebody else has a chronic health issue, or there's some really significant event in the news, you can kind of check in. How is that for you? I mean, it hit me really hard. I was, and use yourself as that barometer. I know I've been thinking about it all day. What's that like for you? Or what's that like for you to be in the school right now? What's the temperature in the school like? Who would you talk to if it was really impacting you? It's normal to feel like you can't quite bounce back on your feet after something like that. But also, who would you talk to? Would you tell me if it was kind of impacting you, so much so that you kind of you felt like you weren't able to really be yourself? Would you talk to the school counselor? Could you talk to dad? Could you talk to somebody else? I think we need to not assume, yes, children are incredibly resilient, and we do have to assume that, but we also have to assume that they have the same set of feelings and less life experience. And so we need to help them process when they experience big events. Hopefully, hopefully there are challenges at times when these feelings come on so quickly that that they get these thoughts of suicide very impulsively. And again, that all I can say is not having access to lethal means in your house is a really critical key protective factor in that case.
Yeah. Thank you so much for your time today, Julie. This has been such a great conversation. I really appreciate all of your thoughts and what your program's doing.
Thank you so much for having me. I absolutely want people to understand that lots of people think about suicide, right? Lots of people, over 13 million people in the U.S. have serious thoughts of suicide. So first of all, you're not alone if you have thoughts of suicide, but most people don't want to die by suicide. Right? There's really good help. There's really good evidence-based interventions that can reduce thoughts of suicide. There's really amazing clinicians and providers out there who can help reduce those thoughts of suicide. Parents and kids and people just need to tell somebody and be honest and try to access that help. But people can get better, and they do get better all the time. So thank you for sharing this conversation and these resources, and really appreciate it.
Thanks again, Julie. That was all really helpful information. I want everybody to know you are not alone in this. We need to help support each other and our kids and our community together and make conversations around suicide be something that is just a normal conversation. Mental health is something that happens to everybody. Mental health is just how healthy our brain is, and we can have challenges within that. And just making it a place where everybody can talk about it more freely reduces that stigma and increases the likelihood that people will bring that information to us. With that, I will say thank you so much for your time today. Please rate and subscribe to our show. It helps us to find more followers. And also, can you share this episode with somebody? That would be great. If you can follow us on Facebook, Instagram, YouTube, and TikTok, that would be amazing. And keep the emails coming to accidentalexperts@gmail.com for future topic requests. Have a fantastic day. Some words from our legal team.
The information presented in this podcast is not intended or implied to be a substitute for appropriate professional advice, diagnosis, or treatment. All content, including text, graphics, images, and information contained on or available through this podcast, is for general information purposes only. This podcast makes no representations and assumes no responsibility for the accuracy or information on or available through this podcast, and such information is subject to change without notice. You are encouraged to confirm any information obtained through this program with other sources and review all information regarding any condition or treatment with the appropriate professionals.
What we're saying is, yes, I am a real therapist, but I'm not your therapist.